Good morning and welcome to Gateway Rotary. I'd also like to take the time this morning to welcome our online audience. We're live streaming like we do every Wednesday, so welcome to our online audience.
Yay, click this.
The Pledge of Allegiance is being led this morning by Mike Harris.
Rotarians and guests, please join me in the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
And Jennifer Walker, would you please do the four-way test?
Fellow Rotarians, please join me in the four-way test of the things we think, say, and do. First.
Is it true?
Second.
Is it fair to all concerned?
Third.
Will it build goodwill and better friendships?
Fourth.
Will it be beneficial to all concerned?
And fifth.
Is it fun?
So we have no visiting Rotarians signed up. However, I do know that Steve Massini is here.
Hey, Lacey.
That'll probably be a dollar fine if you didn't sign up. And then guests. Janine, you have a guest?
I do. Jessica Blose, right here. She's also our guest speaker.
Amanda May.
I brought my husband, Gene Bay.
I was wondering who that guy was that was smiling at me. Hi, Gene.
One more.
Ramiro.
Yeah, good morning. I have with me Commissioner Ty Menser, and hopefully soon to be a Rotary member.
Cameron Wilson.
This pretty young thing is my wife, Jessie.
Yay.
And Tim Brennan.
Mark Harris, retired lieutenant from WSP and soon to be a member in a week or two.
Welcome, everyone. And then we have lots of announcements this morning. Megan and Nate, would you please come forward? Good morning, David and Nate.
So I'll speak on behalf of Megan. So the next week's originally scheduled youth service committee has been postponed to the 30th due to a scheduling conflict. So we'd love to see everybody there that participates, and of course it's open to everyone.
So a new exciting thing for our club, there's a new campus-based Rotaract at St. Martin's University. A Rotaract, yes, thank you. A Rotaract is a group of people, either community-based or campus-based, ages 18 to 30, who gather to just share ideas, basically have a mini Rotary. There's a few differences between a full Rotary club and a Rotaract. The exciting thing at St. Martin's is that it's the St. Martin's Young Professionals. And so it's based on the employees and staff and faculty of the university who will be coming together to learn more about professional development and how to grow up and be an adult. And so the exciting thing here is that our Rotary Club is acting as the Rotaract sponsor. And a part of that is being our speaker pipeline. So our first event is kicking off the new year, January 23rd, with our speaker at Twin Star Credit Union with Corinne Wool. I'm not sure if she's here this morning. And so they'll be coming on January 23rd. As a part of a Rotaract and sponsoring club, all Gateway Rotarians are welcome to come to campus and join us. There will be free food and free swag. So January 23rd, Twin Star Credit Union, Harnett Hall 110 at 3:30.
So have you set up when their regular meetings are going to be?
The fourth Wednesday of every month from 3:30 to 4:30 at the same room is called Harnett Hall 110. I will try and figure out how we can maybe communicate that to everybody in case you guys would like to come with a campus map. There's a parking lot right next to the building, super easy. You get a parking ticket, you just let me know. I'll take care of it. So that's a good thing. So with the Young Professionals group, it's encouraged. No, yes. No, that's a great question. So with all the employees at the university, the topics and speakers and information is going to be geared toward people of that age group, but everyone's welcome on campus. And I foresee a lot of different people coming that are not fitting within that age bracket. Is that it? Is it done?
So you said that you could fix tickets on St. Martin's? So that would make you like the Tim Branagh of St. Martin's.
No. Thank you guys.
And Len Fosher, you have some announcements this morning. Please welcome Len.
Yay, Len. Yay, Len. You're our best Len.
All right, how many people do not have on their phone, do not have the Club Runner app? Do not have it. All right, so shame all these people with their hands up. It's very easy to get, please. Upload the app, you can find out a lot of information. Some of the information you can find out is about some of the upcoming events that are going on. First of all, again, I'm going to point out Crystal's doing a great job of updating us and putting up and scheduling all the socials. So let's hear it for Crystal. And see, when I look at the app, I can see all the different scheduled events. Like the February social is scheduled between 4 and 6:30 on February 7th. So isn't that a great thing? And Crystal, where's that at again? Puget Sound Taps. Now I'm going to scroll down a little bit further, and I see the March socials on there. Also March 7th. It's on March 7th, 4 to 6:30, and that's going to be a cool event because we're doing a celebration of Dr. Seuss's birthday. So make sure you're attending that. Where's that going to be, Crystal?
Top rung.
Top rung. Nice. Now the other ones I wanted to point out was the Paul Harris Dinner. Paul Harris Dinner is scheduled for March 28th, 5:30 to 8 at the Hotel RL. Please sign up for that. Go to Club Runner, sign up for that if you haven't done so. We have a lot of folks that are going to be recognized at this event. So please, please go and sign up for it. I think you'll enjoy supporting your other club members or yourself as you get recognized. And the last one I wanted to point out today was May 9 through 11 is the District 502 Training and Conference. It's going to be in Victoria, BC. That's in Canada, if you want to know that. And we're going to have more information on sign-ups for that upcoming. Thank you.
Mary Weiss, you have an announcement to make this morning. Please welcome Mary.
Yay, Mary.
And Madeline, you will be next. Where did Mary go?
Clever.
There she is.
I'm behind everybody.
I didn't see her.
Thank you.
In November, the membership committee did a program on mentorship, and today I have a sign-up sheet for anyone that would be interested in being a mentor. It has a little bit of a summary of what would be expected. So I'll start it on this side of the room and just read it and set it across the room. I appreciate it.
And Madeline, you have someone to induct this morning.
Madeline.
I just don't have to give you a hard time.
So, I want to know how many people that belong to this club are from Thurston County? Not that you live here, but that you work there. For Thurston County. Are employed by, thank you, Tom, those words, that's a big word for me. So, I have to say that Ramiro is pretty amazing how many people that he has gotten from the county to join. And I wonder if there's anybody left that is a main member of Gateway. Yes.
That's for Romero who brought
Ramiro, who brought you in?
I don't remember.
Yeah. Talk about tickets, Tom.
Ramiro and Mark Daly, would you please come forward? So, Mark does work for the county, but what else about him? He grew up on, what? Kind of, sort of, he doesn't work?
Romero's branching out.
Oh,
Yeah.
where do you work?
First Regional Planning Council, we're not.
That's
actually
not part of it?
the county.
Wow, good for you, Romero.
He's diversifying.
Yeah.
Thank you.
Mark grew up on the east side of the state, Yakima. He is the youngest of 4 boys, with his older boys by 5 years being triplets. Brothers, his older brothers, excuse me. Growing up with older triplet brothers is pretty scrappy. I almost said crappy. Same thing. Mark moved to the west side for college at Western Washington University undergrad and University of Washington grad. He loves this side of the state and can't envision ever moving back east. Mark, his wife Karen, and son Will have lived in Olympia for about 15 years. Mark's wife is a teacher at the North Thurston School District. Mark worked in state government at the Puget Sound Partnership, Fish and Wildlife, and Natural Resources. His time with the state included a year in Governor Inslee's executive cabinet when Mark was the interim director of the Puget Sound Partnership. After commuting to Tacoma for 6 years, headquarters of Puget Sound Partnership, Mark was elated to work back in Olympia when he was chosen as the executive director of Thurston Regional Planning Council in February 2017. For fun, he loves to golf, fish, explore in the woods, and play his drums that his wife graciously lets him keep in a tiny room in the garage. Sound true? Sound true? Oh, good. After spending his 20s and 30s focusing on his family and career, Mark is looking forward to giving back to this community and beyond through the excellent work of Gateway Rotary.
Yeah.
Where am I going? All right. Thank you very much. Thank you.
Help me welcome Gateway Rotary.
Well, there you go, it's gonna be that kind of morning. All right, so this morning, our guest speaker is Jessica Blose. She's a licensed mental health counselor and certified chemical dependency professional in Washington State. Jessica spent her counseling career in New York State, working in co-occurring behavioral health treatment agencies that were also opioid treatment programs and office-based opioid treatment programs. Since moving to Washington, Ms. Blose has worked as a regulator for the former Washington Division of Behavioral Health and Recovery, and is currently appointed as the State Washington Opioid Treatment Authority with the Washington State Healthcare Authority. So please join me in welcoming Jessica. So thanks so much for having me this morning, guys. It's really nice to be here, even though you guys are kind of crazy. This is really, really early in the morning. Do you mean it?
Wait a minute. We're not kind of crazy. We're totally crazy.
Awesome. My favorite kind of people, the mental health counselor. So,
He hasn't even gotten to the drug thing yet.
It's like an absolute OCD problem.
okay. All right, so today we're going to be talking about really the opiate epidemic, what it means for us here in Thurston County, and then what we can do both in our families and our communities that are dealing with this issue. So quick disclosures, as I come from Washington State, there's no conflict of interest that is present with me presenting this information. There isn't going to be any unannounced mention of any type of experimental drugs or treatment, and any brand names of medication that I'm going to talk about today are really just for the purposes of identification for you guys to be more able to recognize it, and does not necessarily represent a specific endorsement from the state of Washington.
Wow. We've never had this
And then again, we're just going to be talking in the next
15 minutes. I'm going to be going pretty rapidly. We're going to save questions till the end. Just trends both in overdose deaths in the state and then here in Thurston County in particular. Again, some of the causes, the main cause of the opiate epidemic. And then again, learning strategies that you can take to help a loved one that's in need of help. And then as a community member or even as an employer here in Thurston County. So we have on this graph that's kind of talking about the upward trajectory that we're really seeing across all types of substance use related to drug overdose deaths. The blue line is all drugs of any kind. So this could include alcohol, methamphetamines, heroin, prescription painkillers. The black line is any opioid, and an opioid is considered, again, anything that's a prescription painkiller, something like fentanyl, and then heroin. And then actually another trend that we're not going to be talking about today is this low bottom gold line. And that line actually represents an increase in deaths related to methamphetamine use. Even though everyone is talking about the opiate epidemic, we're definitely experiencing a methamphetamine epidemic in our country, as well as here in Thurston County. And in reality, a lot of people who are using drugs aren't necessarily using just one drug. So it's an important thing to think about when we talk about this epidemic. So again, this is another graph that's kind of breaking out statewide data related to overdose deaths, but then different types of opioids. So one thing that I'd like to point out, we are seeing a reduction in prescription painkiller related overdose deaths because there's been a lot of work done to educate the public and then prescribers who might work at a primary care doctor's office or a pain management clinic regarding how these, we're actually prescribing way too many painkillers. They're actually the second most prescribed drug class still in all of Washington State after antibiotics. So we are seeing a decrease, but unfortunately what we're still seeing an increase now, since there's less painkillers, is it forces a lot of people who do have an opiate use disorder to switch over to heroin, which is still available through illicit markets. And then that low bottom gray line is fentanyl. So fentanyl is about 10 to 20 times more potent than street heroin and prescription painkillers. And it can result in death with even a very small amount, like the amount that's the size of the tip of a pen. And we've been very fortunate in Washington State that we don't necessarily have a big fentanyl market like there are in a lot of other states, but unfortunately that's starting to change. We're starting to see a jump, and that's something for us all to be kind of aware of in our community. So I also pulled out some local data that's specific to Thurston County, and I'm comparing us with overdose deaths related to other counties that are nearby, like Mason, Grace Harbor, and Pierce County. So as you can see, Thurston County, we're actually doing pretty well compared to the other counties. But one thing I'd like to say is that opioid death, any opioid death, is a preventable death. It's actually the #1 cause of preventable death in our country at this time. It's killing more people than car accidents. It's killing more people than any type of gun death of any type, whether it's suicide or a violent gun death. And then again, it's a chronic medical illness where we do actually have effective treatments for, and then we do have effective treatments for opiate overdose reversal. So we're going to be talking about that more, but again, I just like to say any death is really too many. So another thing that we always talk about, you always hear stuff in the media about death overdoses. It sounds like it's hopeless, but one thing we're not necessarily talking about is all the individuals who aren't necessarily having an overdose but still have a problem. Here's some statewide data about last year. There was about 694 opiate deaths that were noted here in Washington State, but there was 1,451 opiate overdose related hospitalizations. There was 14,389 people who made it to treatment and were identified with opiate use disorder. And then there was another 259,000 people who probably meet criteria at least for prescription opioids. A good rule of thumb is that in any given area, both here in Washington, Thurston County, and the whole country, 1 to 2% of the overall population in an area can be considered as having an opiate problem. And that could be, again, in addition to other types of substance use or mental health conditions. So it's truly a very big problem. But again, I want to give people hope. It's not a hopeless thing. There are effective treatments available, and there's a lot we can do to decrease the impact of this on our community. Another quick graph, it's just kind of breaking out some misnomers I think that exist. Sometimes there's a thought that there must be more overdose deaths and opiate use in urban areas versus suburban areas. That's actually not true. We're actually seeing more deaths in suburban areas, more deaths from heroin in suburban areas, as well as if you notice between what would be considered a large town, and I think the metric is about 250,000 people or more, so something like Tacoma or Spokane or larger size. In smaller towns, which I think a lot of the towns here in Thurston County would be, you can see it's actually pretty evenly split. So really, again, it's impacting everyone, everywhere. So we're going to kind of get into why this is happening. So we do now know that prescription painkiller companies were marketing these drugs to primary care physicians, to people at pain management clinics, and they were not necessarily being honest about the impact that this could have on people and how addictive this medication would be. So as you can see, as over time from 1999 to 2010 in this, as sales increased, we're seeing more increase in people who are having to go to treatment and more increases in death. So for example, Washington State, we are pursuing a lawsuit against Purdue Pharma at this time, and I think it's going to turn into probably a global settlement like big tobacco was in the 90s. And we're hopefully expecting to see a flow of money that might come from that can help communities all across Washington be able to both pay for treatment options for people and then help support community things that we'll be talking about. And then again, one of the things that we are really doing is we are starting to have a prescription drug monitoring program in our Washington State. So anyone who's a prescriber, again, any type of doctor, physician's assistant, ARMP who's prescribing these medications is going to have to start noting it. And again, that is going more fully into implementation. Basically, I think as of the start of this year, but we can already track and see who is prescribing, how much prescribing is still being done. And again, unfortunately, we're still seeing that opiates are the second most commonly prescribed medication of all medications in Washington State. So still a lot of work to do. So super quickly, there's a bunch of things we're doing at the state of Washington to try and address this. We have a Washington State opiate response plan, and we break it up into different parts. The first part has to do with prevention for opiate misuse and abuse, topics related to treatment of opiate use disorder, ways to reduce morbidity and mortality, which is those opiate overdose-related deaths, as well as using data to monitor and evaluate where we're at and if we're actually having outcomes. Another thing we're doing is we're literally funding treatment programs all across the state. As you can see, these are not all the treatment providers across the state in general, but just the ones that we have been able to fund with state and federal dollars. And we actually just started one that is in Olympia. It's at the Capital Recovery Center. We're helping to fund a low-barrier buprenorphine clinic where anyone can get treatment on demand and just go in the evening and see a doctor and start getting prescribed medication right away. So that's a good resource that's right here in our community. And then we'll talk about some other resources. So now we're going to start to get into what can we actually do here in our community to address the opiate epidemic. So one thing we can do is really ensuring that community leaders and community nonprofits and other types of groups that are working with individuals are taking advantage of all of the state and federal grant dollars that are available for treatment of, again, opiate use disorder and community prevention activities. There are portions of the state where we don't get any applicants for some of this grant money, surprisingly. Or there are times there's grant money available, and again, places in Thurston County and the surrounding region aren't necessarily applying. So it's really important to know what's out there, and then again, to be encouraging people to make use of this. Basically, it'll be free money to help our community. Again, ensuring community leaders, and that can be included things like you guys, having me come here today to speak about it, to talk about public education campaigns on both risks related to opiate use disorder and then just what is opiate use disorder. So if this presentation is meaningful at all, if you guys have any other local groups, whether it's a church group, whether it is another community type group, please let me know. We'd love to come and do these types of presentations anywhere. Another thing we want to do is ensuring that all your communities you're in have access to secure medication returns. Lots of times people might get prescribed like 30 days of a painkiller in the past for something like a wisdom tooth extraction. You don't really need to take this medication for 30 full days, so people have leftover medication that they're leaving in their house, and then you know what? Things like teenagers, children, family members who have a problem can come in to access this medication. There are places in the community, and I think a lot of our police departments actually have this, that you can return medication in a safe way and it will be destroyed. Another thing is to support local syringe exchanges and sharp syringe containers in the community. So with this, it really is a cost-saving strategy as well as a public health issue. If we don't have syringe exchanges in our community, we're going to be having hepatitis C and HIV outbreaks. We are, as a state, for example, I think Grace Harbor just voted to not necessarily continue to fund our syringe exchange. So the Department of Health is planning again for HIV outbreaks hypothetically to be occurring in that area, as well as the syringe containers. We all know, unfortunately, how many needles are out in the community, in the streets, in parks. So really, you know, drug addicts are our neighbors. They are everyone. They are going everywhere. They're going to the library. They're going to public places. They're going to the community. So we want to make sure Sharps containers, there's many places as possible. And then again, they can also be used by really anyone else who has to use IV things like diabetics. And then again, ensure things like local health departments, schools, and different training things like local nursing programs that might exist in colleges are really advertising Washington State's new opiate prescribing guidelines. We've made a lot of changes across all the professions where you can prescribe something. So again, that can be doctors, nurses, pharmacists, and this can also be dentists. So there's a lot of changes that are coming to how many opiates can be left out. And for the first time ever too, if someone in here is prescribed a bunch of opiates after surgery, and you go to your pharmacy, and the pharmacy says, well, here's your script, it's for 60 days of opiates. And you're thinking, gosh, I don't really think I'm gonna need that more than like a week or so. You can have the right to refuse to take the full amount of the script, where previously you would have to take the full 60 and then you'd be more likely to take it, or again, it could get accidentally diverted in your household. So another thing related to prevention, words matter. So this is a chronic medical condition. In our field, we like to use medical terms for this. So some words are, you know, someone is clean versus someone is dirty. Someone is an addict, which even I myself just use the term addict. So it's some hard thing to switch away from. Junkie, and then harm reduction. You know, harm reduction, there's actually no chronic disease management that is not harm reduction. When you take a blood pressure medication, that's harm reduction. When you're taking medication for your asthma, that's harm reduction. What we like to talk about is someone stable or are they unstable? Is it a person with a substance use disorder or things like treatment? So again, it's just important to reframe the discussion because stigma around this is so strong. And honestly, I think sometimes it's not even really the drugs that are killing people, it's the stigma. It's the stigma that you can't go to a family member and say that you're struggling. It's a stigma that you can't necessarily go to a doctor and ask for help, or you'll be labeled that, oh, you're just drug seeking. Or it could be the stigma, again, just really related to if you're having problems with your employer, that there might not be a system in place for them to help you and you're worried you're gonna get fired. So again, another most important thing I want to say today, there are effective medications that we have. They're incredibly effective for this substance use disorder. It is a first-line approach for anyone who's struggling with this condition. And then again, people can and do recover. You can get to a point in your life where you're able to recover from this substance use and continue to be a productive member of your community and family. So the 3 approved medications for the treatment of opiate use disorder are methadone, buprenorphine, or more commonly known as Suboxone, and naltrexone, more commonly known as Vivitrol. So methadone and buprenorphine are so powerful, they're actually proven to effectively reduce the risk of overdose by over 50%, and the Vivitrol between 35 and 40%. So really what we want to say is, All of these are good options for people. While just like for a mental health disorder, you might have depression and one type of medication is going to work better for someone, but you give that same medication to someone else, it's not making as much of an impact. We want to say again, really we want to increase the availability of treatment options in places that offer these medications. And if I had a loved one, I absolutely would want to make sure they're going to a place that can at least offer them the choice of these types of medications. So one thing that comes up is how effective really though again is this medication? So we like to show this. This is talking about the impact of a blood pressure medication on someone in a population where you have something like heart disease. So this is meant to be a sample, it's really about per 1,000, but we reduced it just for ease of looking at. So this shows how many people in this sample would die, the red, if they're not getting any treatment. So again, we're going to introduce a harm reduction treatment of the blood pressure medication. As you can see, in reality, it does reduce the rate of death, but it's still, medication is not necessarily the only thing. You have to make behavioral health changes as well, and things like lifestyle changes, and then counseling that can help. But let's talk about one of the medications we just talked about, methadone, which is sometimes the most stigmatized. So as you can see, compared to the last couple slides, the rate of death is much higher for someone with opiate overdose. But let's see what happens when we introduce a medication. So as you can see, it is actually, again, these types of medications are more powerful than really any other medication that we have to offer. There's no risk of long-term use, despite, again, a lot of misnomers that taking these medications long-term can be bad for you. That's actually not true. We now recommend that people can stay on these medications for as long as it's effective for them. And then again, just like a lot of things, someone who's on depression might be able to deal with their depression without any medication. Someone might be on one medication and then switch. Maybe someone will be on a medication for a while and they'll go off. Maybe someone will be on it long term, and maybe someone will go on and off medications for the rest of their life. Again, we just want to say there's no right way for someone to get to their recovery, and again, we just want to have all the options available for people. So again, related to treatment activities in your community, if you have a loved one or an acquaintance who is looking for help, I would really recommend, again, you find a treatment place and ask them, do you have a medication that's available for the treatment of opiate use disorder? Or do you have a place that will allow it? We unfortunately still have a lot of counseling agencies in our state that will not allow clients to take medications and go there for counseling. It's crazy. It's one of the biggest parts of my job is looking for this. It's ultimately discrimination, and we're a protected class in the state of Washington. Another thing, again, increasing the number of office-based opiate treatment programs in the community, asking local health departments to help provide information on this topic to places like clinics, dentists, emergency departments, jails, ensuring that treatment facilities are contracted through city, county, and then even nonprofits to allow medications for the treatment of opiate use disorder. If we're spending money in our community and the money that we're spending doesn't include something with this option or a way to link to this option, we're not really doing a good job of spending our money, whether it's philanthropic or governmental. And then asking if primary care clinics and emergency rooms are actually providing this type of service. Most people are going to come and speak with their primary care doctor, or again, unfortunately have an overdose and end up at the hospital. We found a lot of primary care doctors' offices don't offer this medication, aren't necessarily referring people to this medication, and the same thing with a lot of our emergency rooms. So if you know people in the medical community or in different groups related to that, please share some of this information we're talking about today. There's special activities for special populations. We can have more culturally specific prevention and treatment geared towards Native Americans, along with public education campaigns. For pregnant and parenting women have different needs. Outpatient, residential, and hospital-based treatment should be available for women who are looking for services for them, whether they're pregnant or again postpartum and they've had their infants. And then providing information to local foster care agencies. There's these questions about, well, how could this woman be using drugs in her home with her child? But in reality, a lot of times, they're doing it because they want to stay at home and keep their kids safe as opposed to being out in the street. But sometimes we almost stigmatize and penalize women more so than other types of people in recovery. And then for criminal justice related things, we really want to work on implementing pre-arrest diversion programs. It's the best use of money to help get people into treatment. Because a lot of times what people need is treatment and not necessarily incarceration. But then we also want to make sure any therapeutic court in our area does not offer discrimination against people on medications. We have lots of drug courts all across Washington that actually won't allow some of these medications we just talked about in drug court, and it goes totally against the public health policy. Having treatment options available for individuals who are incarcerated, and then linkages to continuing care once someone gets out. We're also going to talk quickly about activities to prevent death from drug overdose. So you've probably been thinking, why hasn't Jessica mentioned anything about Narcan or naloxone? That's because it's not necessarily indicated for the treatment of opiate use disorder, but it is indicated for the reversal of an opiate overdose, which is what is the fatal part of opiate use disorder. So there's a great website, stopoverdose.org. On that, they have a really cool app. You can type in your location, and it will tell you where you can get Narcan in your community. It will tell you if you can get it for free, if you can get it through, again, a county health department, if you can go purchase it at a pharmacy. And really at this point, we want to say anyone should be having this. The Surgeon General did a report last year, said everyone should carry this medication because it's such a big problem. So again, we do give it out right now as syringe exchange programs. We want to make sure first responders in an area, whether it's police, EMT, paramedics, Sheriff's Department, Fire Department, have access to this medication. Giving it to treatment facilities, jails and ERs, having it available at local pharmacies, community centers should have this. Schools, can have this. And then business owners should be able to have something like this because you never know if it can affect your employee, the customer, or someone that's outside of your business. And then the last thing we're going to end on really is activities employers can take. So anyone in this room who, again, has a business that is an employer, there's lots of things we can think of doing differently to help this. One is reconsidering how you utilize work-related drug tests. So if someone tests positive for an illicit substance at your workplace and a random drug test, is there something like an employee service program that they can be sent to? Do they have an option that they can be sent to treatment as opposed to having to let them go and then sometimes finding a new employee, bringing them in, retraining them, actually ends up costing way more money to a business as opposed to if you're willing to work with someone. Or again, if someone tests positive for one of those drugs that we just talked about, if it's a prescribed medication, to not penalize them for getting the help they need. Educating and empowering employees. Companies can provide training and education to their employees on opiate use and mental health issues and encouraging safe medication disposal. You can train your supervisors to recognize the signs that someone might be struggling with a substance use disorder and then refer them to a program for treatment. Implementing robust access to high quality mental health services and employee assistance programs. So again, stress, mental illness, alcohol abuse, long-term post-surgical recovery, all these type of things can contribute to someone becoming addicted to painkillers. And employees should be encouraged to access an EAP or use their medical plan benefits to do things like go to counseling, get rehabilitation services, go get a health assessment screening that will help monitor them for ongoing drug use and give them help what they need. Consider covering within your insurance plans alternative pain management options. Do the benefits that you're offering to your employees, does it talk about things like lifestyle adjustments? Does it cover behavioral health therapy? Will it cover those medications we talked about? Does it pay for things like exercise, acupuncture, massage, chiropractor? Things that people can take in addition to opiate overdose if they're dealing with chronic pain. Especially if anyone in here works with people who are in really hard, physically demanding labor jobs, can make an impact. And then just implementing utilization management to encourage evidence-based safe prescribing and considering implementing locking in how much medication of a certain kind that your employees can get. So I know we're running short on time. Just want to end with, if you're looking for assistance, there's a 24/7 helpline in Washington State called the Washington State Recovery Helpline. You can find it online. You can ask them where there's a treatment in your area. And then also another thing, in the summer of 2018, Thurston County actually declared that there's an opiate epidemic in Thurston County, and they started to convene a Thurston County Opiate Response Task Force that's meeting right now about monthly. I'm a member of that. Lots of people in this room are a member of that, but we still need more representation from our community. We need business owners, community organizations, just individual members of the community and people with lived experiences to come join this group so we can come up with the best plans to work. But anyways, that's it in 15 minutes or less. So anyone, do we have time for questions or did I go? Cool.
There's something I don't understand about the opioid crisis. It seems in the press we're hearing mostly that it was the fault of big pharma and their sales efforts to the medical industry to convince them to prescribe these drugs, right? What I don't understand is, I mean, since the time of Sherlock Holmes and opium dens in the Middle East, we've known that opioids that people get addicted to these drugs. I mean, this is not, I mean, I got a poli-sci degree and I know that. And so what I don't understand are people that go to medical school for all these years are acting like they're babes in the woods when they're, learning about these drugs. I mean, opium's been around and derivatives have been around for a long time. I just find it incredulous in the fact that we're still, I mean, I just had a back problem and you're still getting 60 days worth of these drugs. Even today, it seems to me that's where the problem is, not with, employers, right, doing the wrong thing.
Well, definitely. And like I said, I don't think employers are doing the wrong thing. It's just things that maybe you could do in addition to. But it's a really good point, well taken. And I think part of the issue is that, again, when these drugs were marketed, they were originally marketed, this is a chemical variation on something like opium. We've been able to reduce some of its addictive properties. And if you want to prescribe it for 90 days, you can, and the person won't end up addicted. And in reality, what we now know is that even 20 days of an opiate can increase your risk of having opiate use disorder by 25%. So in reality, you're right, I do think prescribers also have played a role in this, but that is part of why we have started to develop prescribing guidelines that are really specific. And traditionally, doctors have really had a lot of autonomy to prescribe whatever they feel is necessary. But you're right, I think the medication is clearly still being overprescribed at this time.
When oxycodone and its relatives were new on the market, there was a lot of conversation in the press about untreated pain and that there was this massive need. And you mentioned at the end some of the ideas that are coming out about pain management and some of the alternatives. But I guess part of my question is, was the problem generated in order to sell the drugs, or is the problem still there? We have the opioid crisis, but we still have the root problem that we were trying to address at the beginning.
Really important question, because you're right. There is, people have chronic pain. It is legitimate. Some people with opiate use disorder have legitimate chronic pain. And actually, if anyone takes a medication that's one of these painkillers for a long period of time, every single one of us in this room would develop tolerance and withdrawal symptoms. That's just physically how our bodies would relate to this medication. You don't necessarily develop opiate use disorder unless you have other criteria as well. So I want to say that people who are taking long-term pain management and have become physically tolerant, physically dependent on these medications should not be considered those who are on opiate use disorder. But you're right, it's like what came first, the chicken or the egg type of thing. And how many people in this room had been to a doctor at one point and they would say, what is like your amount of pain on a scale of 1 to 10? And then that was actually a tool that we now know was marketed originally by some of these drug companies, that it was supposed to be the pain is the 5th vital sign that you need to check for. And then again, traditionally we haven't as a society necessarily offered a lot of other types of pain management. Here in America, sometimes we're looking for what is like going to be the easiest solution, and we're looking for this quick fix. And take this pill and it will resolve all your pain. But we also now know that, you know, there's other ways to manage pain, and that sometimes just taking this pill and taking it for long periods of time is going to result in someone having an overdose.
So I will say that we took advantage of the grant program to fund all of our Narcan for the next 5 years, and it saved us about $16,000 over a 5-year period of time. And every deputy, the jail, all the offices and everything at the county here have the Narcan available. Thanks.
So this morning, I'm just going to take a quick moment to say goodbye to our online audience. Thank you for joining us, and we'll see you again next week, or better yet, you'll see us.
Yeah. Goodbye.